Well, good evening and welcome to the Institute of Health and Social Care Management and the latest in our HealthChat series. Tonight, we are so thrilled to be able to welcome Professor Marcel Levi, who's just finished as CEO of University College London Hospitals. Before we go to Marcel and Roy, though, I'm going to ask Richard Strong from our beloved sponsors, Allscripts, just to say a couple of words. Richard.
Thank you, John. And welcome, everybody. As always, Allscripts is delighted to be sponsoring this health chat, which I'm certain will include some fascinating discussion, debate, and some great insights from Marcel. But before I hand over to Roy, I'd just like to take the opportunity to thank Marcel and everyone in the NHS and the social care sector for everything they've done for the UK population over the last year. It's been truly amazing, and I can't believe it's a year already, but thank you to everyone. I hope you enjoy the session. Over to you, Roy.
Richard, thank you very much, and good evening, everyone. If you're watching live, it's great to see you. If you're watching a recording, it's great to see you as well. And Marcel, well, you were, I think we were the first people that you had a conversation with when you first came here and took on the job after Bob the Builder. And I think now this is the first interview since you've left. So I guess there's not much happened in between when we last. What's it like to have been a has-been? I don't know. What do you look back on?
Yeah, great question. So in the first place, thank you for inviting me. It's absolutely great to be here and to share some thoughts with you. Yeah, what's it been? Well, I have had a fantastic time at UCLH, in the NHS, in London, and in the UK. And I came through the UK with high expectations about the NHS, about UCLH. And actually, I think everything that I've experienced have exceeded that expectation. And I've learned a lot. I learned a lot about the NHS. I've learned a lot about the UK health system. I learned a lot about the country. I love the city of London. And I have also learned a lot about my home system in the Netherlands. Positive things and things where we can improve.
It is interesting. I mean, why don't we start really here at the end? Because you've left really to go and work in government, haven't you? It's a really interesting job. Just tell us what you're going to be doing.
Yeah, it is. So it is a job with, well, if I have to make a comparison to the UK, it is somewhere in between Chris Withy and Patrick Vallance. It's a new job. They didn't have that in the Netherlands, but there's lots of criticism sparked, I think, by COVID, that the government should have a national advisor on both science and healthcare. But, you know, the Dutch, they're not going to appoint two people. So if they can save a little bit of money, so they are going to appoint one, and that's me. And it's a combination. So it's an advisor job for the government, but at the same time, I'm the president of the National Science Organization. And that is a funding organization like UKRI or in the old days, the MRC.
It is interesting, isn't it? I mean, we've appointed someone now to be the sort of head honcho of pandemics and getting ready for the next one. One wonders really the extent to which there will be an enthusiasm for getting ready for the next one once this one has sort of paled into insignificance. We've all sort of moved on, forgotten about it. I mean, is it possible for governments to keep an impetus to prepare for a pandemic? We don't know when it's going to come, even if it's going to come in 100 years.
Yeah, I think it's a very relevant question, and I'm thinking about it all the time. And I think so for example, if we are going to prepare for the next COVID, whatever it's going to be, and we will have massive stocks of mouth masks and PPE and all kinds of respirators, it may turn out that the next pandemic is actually a gastrointestinal disease where we don't need any mouth mask and we don't need respirators, but we may need something completely different. So it is a little bit preparing for the unknown. And I think I'm a little bit skeptical about all those people who think you can prepare for those things. I think what you can do is actually build up an organization which is very agile, which is very flexible, that can immediately chime in when there is a problem of this size somewhere in the future, hopefully not in the very near future, but you never know. But it is, I think it's an illusion to think you can prepare yourself for everything. Because there may be a next pandemic, but who says that that's going to be a respiratory disease?
Yes, and I think, I mean, this is years ago now, but I used to be the leader of my local council, and I was the chairman of the health authority. And because of those two connections, I got sent to the Easingwold College. Easingwold's a place in East Anglia. It was a civil defence college where we went, and it was a very long course. It was residential for about a month, I think, where community leaders were sent to prepare for emergency response. And it was, I have to say, it was pretty grueling. And at the end, we did an exercise where we were in a bunker. And because at the time, the world was worrying about nuclear war. And, you know, we were telling people to hide under the table if someone was going to drop an atom bomb on their house. And it's ridiculous, really, but it was all we had. But we did this whole gamut of emergencies that we would prepare for. One of them was actually a sort of pandemic, but the course of it was plotted, and it fizzled out after about 6 or 8 weeks. So here I am, a trained person who had absolutely, I would have had no idea how to deal with this thing that's carrying on for a year, and who knows, he's likely to carry on for another year, certainly 18 months. And then we look at Operation Signet, which the ministers were preparing just 2 years ago, weren't they, when Jeremy Hunt and others did their training, and they trained on a flu epidemic, not a pandemic, and they were totally unprepared for it. And I think, you know what, sorry, it was just rather long diatribe from me, but I mean, it just, you triggered it when you said preparing for the unknown.
Yeah, because it might well be, so that's the difficulty, and it might well be that the next disaster that will come to us will be a cyber attack. I mean, not the cyber attacks that we know now, which are already quite disruptive, but let's say a worldwide cyber attack. And how are we going to respond to that? So it's not necessarily a disease or an epidemic or a pandemic. It could be anything. So I think if you want to prepare yourself for these things, you have to have a general organization that can respond very quickly and very rapidly to bad things that may happen to us, to all of us in the world. But thinking that you can prepare very precisely for what's going to come our way, I think is an illusion.
It is. I mean, when you were here, you had to deal with WannaCry, didn't you? The ransom attack on the NHS.
WannaCry was interesting. I think when I came to UCLH, I think our IT systems were so extremely outdated that they did not even tolerate WannaCry. So we were not affected at all by WannaCry. But the only reason for that could be that we were so much behind the rest that the virus didn't get in.
Yes. The other point I just wanted to, I mean, we should talk about the NHS, but this is really interesting to talk about in the future. The role of the politicians in this, because, you know, we've been told that, oh, well, we followed the science and we followed, you know, what the experts have told us. I mean, and clearly that hasn't been the case. I mean, I'm not trying to lure you into a political fight. That's not my purpose. But but the purpose of an organization like yours and the one that we're setting up here would it not, to have a much more robust influence on whoever the politicians of the day were, to make them make the right decisions.
Yeah, that's a good point. I'm not going to complain too much about wrong decisions in the last year, because most of these statements are retrospectively, and it's maybe very difficult when you have to make a decision that deals with the immediate future. There are a couple of observations. One, the quality of the chief advisors of the government is extremely high. So the likes of Patrick Vallance, Jonathan Van Tam, Chris Whitty, they are world-class people. And that's not true everywhere in the world. So the infrastructure of having fantastic, high quality medical and scientific people there to advise the government is available. Then, of course, politicians sometimes make mistakes and deviate from the advices, which is in their right. I think, why not? I think where it went wrong is when they actually did not look back, did not evaluate their own decisions and say, well, this may have been a wrong decision. We may have to turn back and actually do the right thing. So usually it takes a long time until politicians admit that the decisions they've been taking is the wrong decision. I'm just thinking, and again, I don't want to be malicious or negative or whatever, but I think in December, what happened is a very good example. The scientists said we really are heading towards a very bad next wave of COVID. The government resisted, Christmas was coming, and then it took them a very, very long time, a much too long time, until they decided that there should be a lockdown. And in the meantime, January happened, which was the worst COVID peak that the world, I think, has seen so far.
Yeah. Yeah. And of course, there's a kind of latency in the decision making that, as you say, it's very hard for politicians because of the confrontational nature of politics, where the opposition they'll say, oh, yeah, we're all going to work together on this. But actually, they don't. They're just looking for reasons to be critical. And so if you've got a vocal opposition looking for reasons to be critical, and you've got a government that's really on its back foot, as most governments were, then they're going to be even less reluctant, or even more reluctant to change their mind, because changing their mind will make them look indecisive. And if they look indecisive, it looks like they're not in charge. And it's a kind of recipe really for delays and the wrong decisions, isn't it?
Yeah. But to be honest, I'm quite tolerant to politicians. It is a difficult job, and people will always criticize you. If you do things okay, they will never say, oh, that was a fantastic decision, and therefore we did not have that second wave. They will just say nothing. But if you make a wrong decision and bad things do happen, then people are very easy to blame them. Yeah. I think the only thing which I think is which politicians should learn from the previous few months, or actually year, is that they do need to realize that they are surrounded by very good people, very good advisors, that they need to listen to them. And the thing that I really found not very elegant from politicians was this whole business of giving jobs to private companies, persons who wanted to earn money, who made a fortune in the pandemic. Let's be real, a fortune because of the suffering of other people, and all kind of business transactions which were not really straightforward. That's what I really didn't like. I've said in one of the exit interviews I did that everything they asked from the NHS has been a success. Let's remember that, how strong the NHS is, how resilient it is, and how capable it is of addressing the most enormous problems. Everything that's been asked to Serco the list is endless. I'm not going to name all these companies, has actually been a failure. That should be an eye-opener for government, I think.
It is, but just to sort of exploit that for that sort of theme for a moment. If you look at track and trace, for example, I mean, that was hugely criticized, and rightly so at the beginning. But you've got to, we had nothing like track and trace. We had nowhere near the amount of testing capacity that was needed. That was why we had the lighthouses set up. Local authorities did some track and tracing on a local level, but they weren't really robust enough to do it. Public Health England only had funding for 10,000 tests a year, and were only staffed to do the assaying of tests, not to approve laboratories. So all of it was all too small. And you can sort of imagine, sitting around the table in number 10 thinking, okay, we need this massive track and trace thing. What do we do? And you think, well, we need a call center. Who's running the biggest call center? Go to them. And so it was Serco. You know, we need bigger laboratories. How do we do that? Geez, I don't know. Go to an industrial estate, build me 6. You know, you could kind of, I kind of get into that mind frame.
Yeah, that's in itself, that's true. But what's the track record of these companies making things a big success? And it wasn't there. And also, how was the contract structured? So if these people come to you and say, well, I am, you know, this Deloitte or whoever, I'm going to do this for you. Why don't you say, well, that's fantastic, but we are only going to pay you if it works. And we're not going to throw, I don't know how many billion to you, and then find out that it doesn't work. And then, well, everybody's sorry, but the money's been spent and nothing has happened.
Yeah, but then Marcel, you'll end up with a row over what works. You've got to define what works.
Yeah, but what I also wanted to add is there is a slight tendency in the UK to talk ourselves down, because I don't know of any country in the world except for a little bit totalitarian regimes where track and trace did work in the early days, and where they could easily do that much testing. So I think the UK has suffered a lot and may have made a couple of mistakes in COVID, but actually a lot of things were actually quite successful, much more successful than other countries. But we still... Yeah.
And we interviewed Matthew Gould, who on the program, and he was very forthcoming. He said the reason that the app didn't work was everybody kept changing their mind.
Yeah, yeah. And that in a city, well, and of course there were many unknowns, and it was a moving target. So I'm quite tolerant for all these things. It's very easy retrospectively to criticize all these things, but it was all new to all of us.
Yeah. Well, listen, let's take you right back to when we first met, because you were just in post. You were following in the illustrious Bob the Builder, who he just got his knighthood, I think, and he was on his way. Of course, he was a big name in the NHS at the time. I mean, he's still a force to be reckoned with. But I mean, that was a kind of difficult act to follow, wasn't it? And there's a management lesson here, I think, that you could probably talk to about, you know, how do you follow into a job that has been done really very well by a very liked and very respected person? How do you, where did you start? What was your thinking?
Well, let's start by saying that Robert Naylor was fantastic for UCLH, and he created an infrastructure that is probably unparalleled in the UK, with new buildings, facilities, bringing hospitals together, creating a fantastic infrastructure where you could actually practice medicine and do research in the best possible way.
He was amazing. I mean, there was a story that we used to tell about him, that if you dropped a bus ticket outside his hospital, he'd have planning permission to build a hospital on it before you could pick it up. You know, he stopped running hospitals, and he was like in a giant building frame of mind.
I think he was better in doing that than anyone else. And I'm not going to, that was not easy. It's still not easy, as you know, but that was very, very difficult. So he did all that. I think when I came, I think the board was specifically looking for something else. So I'm not a builder. I don't know anything about planning permission, about buildings, about all these investments, PFI structures. I'm totally blank on all these points. What I know is actually how to run a hospital, how to integrate research and medicine, how to improve quality and safety. And I think the board thought, well, now we have all these fantastic buildings and all these fantastic machines and equipment, but how can we become an even better hospital than we are? And how can we be a more research hospital than we are? And how can we better use that fantastic university that's just on the other end of the street, and so forth and so on. So I had a completely other assignment, to say so. And that was really helpful, because nobody had to compare me with Robert, because I had another job. I was going to do something else, very much helped by everything that he achieved before me. And I think, just jumping into the now, that my successor will also have a next job that will be different from my job. And that's good for hospitals. So you need to have a change every, 5 or 10 years, There need to be a change, and the board need to think, what do we actually need now for the next few years, and who will be the person who is going to lead on that?
That's a really interesting point, Marcel, because that's really the strategic direction of the organization is what the board is supposed to do. But of course, so many boards get sucked into the here and now, don't they? They get sucked into this sort of executive running of the hospital, and they're they're focused on, you know, what's happening this week, next month. You've got government pressures on the one hand, you've got pressures to deliver on the other, and it's very hard to get that helicopter view and maintain a strategic vision.
Yeah, no, I completely agree with you. And I think it was the board at that time, led by Richard Murley, the chairman, who developed a very clear vision on what do we actually need for the next few years. If they would have looked for a copy-paste version of Robert Naylor, I think it would have been a failure, because he would be very hard to follow up. People would compare him. It would be less successful. And actually, it was not what the organization needed. And once again, now I'm leaving. I had a couple of conversations with our current chairman. I said, well, you probably need someone else, just, you know, for the new things that need to be done in the next phase. We're entering an integrated care system. We are going to be a completely different organization. You have to look for someone who fits that particular purpose.
What did you change when you went in? Did you, because he had the management structure, I know, was quite complicated, wasn't he? He had medical directorates, about 150 of them or something, I know, very good, and they all ran as individual cells, and the reporting mechanism was through them.
Yeah, so the structure itself is not bad. It is a structure which is a little bit different from most of the NHS. It is a structure where the professional is in the lead. So most of the hospital is run by professionals, doctors, nurses, allied health professionals. I like that system, so I did not change that at all. But as you say, if you have such a system with divisions and medical boards, the disadvantage may be that everybody takes care of himself or herself, but actually there's not a lot of cohesion. So one of the things I had to do was actually bring it all together, try to make them to work together, to look a little bit over the fence, what the neighbors were doing, how could they work together and not only look for things that were in their own interest. And I think, it's not really modest to say, but I think after all these years, that really happened. And that made that organization a much more cohesive organization, still an organization that's led by professionals, which I firmly believe in, but in a much more cohesive way than they did before.
Yes, the common purpose, the strategic vision, and getting everybody, I guess, marching in step. It's a tired old metaphor, but that is quite difficult to do. And then, because you weren't here for very long. Well, I suppose you were here for a while, and then suddenly COVID hit you. Yeah. So, what happened? Can you remember?
Yeah. Oh, I do remember. I think it was, well, the last year, to be totally honest. I love to work in hospitals. I love to work long hours and really hard. But this has been the most intense period of my working life for various reasons. In the first wave, it was the uncertainty, the stress, the staff that was really felt unsafe and insecure. We didn't know what was happening, where it was going to end. We did not have enough materials, oxygen was not enough, all these things. That was the first wave. The second wave that we've just had in January, February was very different. We had all these things. We were actually very well prepared, but then the number of patients was suddenly so big. And then also the increase was so steep that was another stress factor where I thought, well, where is this going to end? What it did actually, COVID is of course the common enemy. So the hospital came together in a way I've never seen such a big organization coming together. So everybody really stepped in, did its best. The vast majority of people absolutely outperformed, did jobs out of their comfort zone without complaining in very difficult circumstances, kept very positive morale, very cooperative, extremely hardworking, lots of energy, supporting each other, because it was also it could be very, very stressful for people on the wards and in the intensive cares. So that was actually a very positive thing for the hospital. And another thing, and it may sound very strange, but when I was talking to our staff, and we did lots of communication because I found it really important. So if everybody thinks the hospital was the worst place to be, it was all hell, it was all terrible, everybody was really working hard and crying all day. That's not true. If I think of UCLH, I think most people felt, okay, this is what we're really good at. This is what we've been training for. This is what we can actually offer to patients in the best possible way. So let's go for it. And I think that spirit was really fantastic. And I think you will meet a lot of professionals in UCLH who say, well, besides all the horror and the terrible things that happened to our patients and that we were almost overwhelmed and all the stress and everything, it was also from a medical and quality and safety perspective, a very good year, because we were caring for patients, and that's what we're here for, and that's what we're really good at.
Yes, and it's interesting, isn't it? Because you're a clinician and you were working on the front line.
Yeah.
How did people react to the fact that when you took your mask off, it was the boss?
Yeah, so they love it. And I'm doing this already for years and years, also before I came to the UK. I think it's very helpful for my role as chief executive. It tells me a lot about the hospital, but also I like it. And the staff really loves it because they say, oh, wow, we now have a chief executive who really understands what makes us happy, what's frustrating us, who really sees with his own eyes how the computer system is working, how radiology is functioning, all these things that people write about, complain about, talk about, but are sometimes very remote from the boardroom. So the responses were very positive in this very difficult situation when we were indeed almost overwhelmed by a lot of very sick people. It was just another pair of hands and a little bit of brain to help people to do their jobs. So it was extremely positive. And actually, it was completely diffused through the organization. So we had a director of dentistry who is a fabulous man, but he's a dentist who started helping on ITU. And we had our chief nurse, who is the most fabulous chief nurse in the NHS, Flo Pennell-Coates. She was not only co-leading the emergency response, but she was everywhere and nowhere, supporting nursing staff, supporting allied health professionals, making things work in the hospital. So I think it made the whole leadership very visible, and that was very positively appreciated by staff.
Do you think that there should be a preference for senior people in hospitals to be clinicians?
I think you need a mixture. I still think a hospital is maybe better off with a lot of professionals, not necessarily only doctors, could also be nurses or physios or any other allied health professionals, but clinicians in the top of the hospital. Obviously, you also need very good financial people and people who know a little bit about workforce and all that stuff. But I think it should be a mixture. And in many boards now, you see a majority of people with a managerial background. And I'm not always convinced that that's the very best thing to have.
I agree. I mean, I've spent my entire life in management one way or the other, either private sector, local government, or in the NHS. And I've always thought, really, what am I doing here? I always sort of had imposter syndrome because I've always thought hospitals should be run by doctors and nurses. It just seems to be a no-brainer. If I was running a business, I ran all sorts of business in my time. And, when I ran an engineering factory, the place was run by engineers. It just seems to be straightforward.
It is also, it makes your job easier. So I do remember, if you're in a chief executive position, then of course, once in a while, the nuclear medicine people come by and say, oh, we need to have another cyclotron, because if we don't have another cyclotron, patients will die. And for me, it's very easy to say, well, I don't think so. And off they go. Whereas if you're a non-clinician, what can you respond to experts that are coming into your office and saying people are going to die? Well, then you buy a cyclotron, which is totally useless. But I mean, the conversation is completely different if you talk between colleague clinicians than if you have a conversation between doctors and the manager, of course.
Yes, I mean, clinicians in management, this is something that, at the IHSCM is a chestnut for discussion. and always has been, and I guess always will be amongst our members. But I think that, I mean, the other side of the argument, Marcel, is to say, well, look, we invest a fortune in these clinicians to look after patients and make them better. It's the manager's job to create the environment where they can do that. Where my job is to find good people and let them do great things by creating the space to do that. And a manager's a manager and a clinician's a clinician.
Yeah, but if that's your attitude as a manager, that you're there to support clinicians and to make their job easier, then that's totally fine. But if you are, as a manager, actually disconnected to that, or not completely connected to that part of the organization, things may get difficult.
Yeah. So, okay, let's talk about the NHS. We're in the middle of another reorganization where we're going to scrape the last vestiges of Andrew Lansley off our boots, I hope, and get back to some sort of structure that works. I don't see really, I mean, I do get integrated care organizations. In fact, I used to run one. They're called district health authorities. And I think you still have district health authorities in the Netherlands, and they work very well. But I'm just wondering, in London, where you've got such a congestion, you've got a bleed over of the boundaries, you've got an enormous number of very, very good hospitals in London. Are they still relevant? I mean, ICOs you're just going to be dominated by secondary care. It's hard for primary care to get a look in, isn't it?
I think you have a point, but I've become completely convinced of the utility and effectiveness of integrated care sessions in this last year, because before COVID, we were just very, very carefully starting to work together, but at a very slow pace. Then COVID came, and suddenly we were all working together because there was a necessity, a clinical necessity. It was not because we had to save money. It was not because there was, somebody said that we needed to do it. We just did it because there was a clinical necessity, and it worked beautifully. So for the first time, we were really helped by mental health institutions. For the first time, primary care and secondary care were really working together. For the first time, community care was really offloading hospitals and took all the patients that did not need to be in hospital. And it worked fantastically well. And why? Because there was clinical necessity, and I can only speak for North Central, of course, but I think it was similar in most of the 5 London ICSs, because people trusted each other, and because they think, okay, if you say this is the best thing to do, let's do it. And the third thing was, we didn't have endless meetings and PowerPoint presentations because we had no time to do that. We had to do things. And that is actually my plea for the next phase of the ICSs. If this is going to be another ocean of PowerPoint presentations, endless meetings that all repeat themselves, endless discussions about terms of reference, but nobody's talking about what's the necessity, what are we actually going to do as an ICS, then this is going to fail. So I think we have learned a very important lesson in the past 12 years that can help us how to develop very solid ICSs.
Yeah, the key organization, it seems to me, in the reorganization is the whatever happens to the CCGs, because they are supposed to be subsumed now into their successor organizations. But already people are writing to me saying, guess what? I've had to reapply for my job.
Yeah.
Through all that again.
Well, so the point about CCGs is, so they will have a very limited role. I can see a strategic role for CCGs, but that can actually be done by a very small, condensed organization of a few people who every few years actually make plans on what would be the important things to do in an ICS. But these big CCGs full of people working there and doing all kinds of jobs and contract negotiations, that all needs to go, which is fantastic because it will be a big saving. And all these GPs can actually help doing frontline primary care. And we really need them.
How often do you meet with GPs, Marcel, or did you meet with GPs?
Oh, I love GPs. So I do meet them very often. My father was a GP, so I always been fond of GPs. And actually, I've met the most wonderful GPs that I've ever met in my career, who do the most fabulous things and run fantastic practices. But the thing is, the GPs that we meet in hospitals is a selection. It's a very positive selection of very well-willing, hardworking, innovative, nice GPs. And there is another group of GPs that you never see that actually do run small practices that are not very innovative and not really keen to change. And I think with the whole change that we are now seeing to PCNs and cooperative organizations of GPs, I think that that's a move in the right direction, where we actually are going to talk to all GPs and not only this positive selection.
My worry is that we're going to lose the essence of family practice and we're going to start to industrialize primary care.
Well, Roy, I think we have already lost the essence of primary practice. And that is because nobody wants to work 100 hours a week. My father worked 100 hours a week. And he did deliveries and he did emergency care at home. And he was always there and he was always working with his patients and he never had a day off. That's not acceptable anymore in current times. So I think we have already lost that sense of continuity of that doctor that is always there for you. So it has to modernize, it has to innovate. And thereby it can much easier integrate with secondary care services and community care and all the other mental health, etc.
Yeah. Just looking back on COVID, I mean, it's been a disastrous time, isn't it, for a lot of people? We've lost loved ones and colleagues, and we should never forget that. But as you've hinted, it has brought out the best in people. It has brought out innovations. I mean, you know, God knows I've been around the NHS for long enough to, you know, we've seen more technological innovation in 4 weeks than I've seen in 40 years. Do you think we can hang on to that spirit of can do and innovation and change? Because that's the essence, isn't it, of what made COVID a success. And if we're going to, you know, the great trick in change is to respect the past and take the best into the future. That is the best. Can we do that, do you think?
Yeah, I think so. So for me, an interesting learning point in practice was that transformation, because what you're describing is a lot of transformation. We've been talking about transformational for decades already, and it never really worked. And that is mostly because we wanted to have transformation because it could save us money. In COVID, money was actually not the driving factor. The driving factor was we want to transform things because we need to do it. So we suddenly moved all outpatients to virtual visits and telephone clinics because patients could not come in hospital anymore for medical reasons. And it worked beautifully well. It was not because somebody had thought, oh, we're going to save a couple of millions by just cutting outpatients, because that never works. So I learned that you can make rapid and successful changes in healthcare if there is a medical necessity, if there is a medical need, and then the clinicians will just do it overnight. And thereafter, there may be an incentive in terms of saving money, which I think is still important because we cannot spend endlessly on the system, but it should not be the other way around. Oh, we want to save money, so we're going to do this and that, because that simply doesn't work.
No. And of course, the tariff is a big issue as well, isn't it? I mean, a lot of your income comes from outpatient appointments. It's a steady income stream. If you're going to do it remotely on a FaceTime, it's going to be a lot cheaper and people are going to pay a lot less.
Yeah, but so it's nice that it makes a lot of money, but if it's totally useless, why do we still do it?
And because it makes a lot of money and your budgets are structured around doing it.
I know, but then we have to change that, because I do agree that a lot of outpatients work. So the system we've built is a system that a patient with a chronic condition needs to come to hospital 4 times a year. In our situation, travels a long time. sometimes need help from children who then have to take off from work or school or whatever. Then they come into hospital after this very long trip. They sit in a waiting room for 30 minutes or longer. Then they talk to a doctor for 10 minutes. The conversation goes like, oh, everything goes well. Fantastic. I'll see you back in 3 months. And off they go. But if next month they have an acute problem, they have a very difficult time getting into hospital. So our system is completely wrong. We give the wrong care at the wrong time. So we spend a lot of time, patients' time, but also our own time on when everything is fine. And we make the system almost inaccessible when everything is not fine. And then everybody needs to just to drain to A&E, which then, of course, is overwhelmed.
Will you carry on with remote outpatient appointments?
Oh, absolutely. Absolutely. I think there's so many things that will save a lot of time. Of course, we will have a blend, because sometimes you just need to talk to people if you have a difficult conversation, or just if you have to catch up, or if you think, well, I do not think my advice have come across very well through telephone or virtually. But a lot of checks and controls that we do in clinic can easily be done, well, maybe even by email, but also virtually or by telephone.
Is there an issue for as you know, talking to you now as a clinician, is there an issue around training for that? I mean, we don't really train the youngsters in medical school to do this, even though they're all tech savvy.
Yeah.
But there is, I mean, years and years ago now, I wrote a book about telemedicine, and one of the big problems with telemedicine was that the clinicians, although they were adventurous and wanted to give it a go, they were worried that they'd miss something. They were worried that they would be criticized, that, you know, their license would be jeopardized. There was a kind of whole nervousness about that because we hadn't introduced them to how to do it properly.
Yeah, I so agree with you. So we train our doctors for a very long time, and they know everything about electrolytes and about, you know, surgical procedures and imaging and everything. But then suddenly you're a doctor, and then you have to run a very busy shift in an A&E, or you have to do a full clinic, or you have to manage a hospital ward. Nobody has ever explained to you how that really works, and how you should do that, and how you can do that most effectively and efficiently, and what works and what doesn't work. There is no single course in medical school that teaches you those things. So the only thing you can do is just look at your senior and see how that person is doing it and copying that. But that change is very difficult to achieve, because people are just going to do what their predecessor was doing. And it's very hard to change. So I'm very big advocate of actually structurally explaining to people what logistics means in a hospital, how you actually prioritize things, how you, what are the financial implications of decisions that you make as an individual doctor, and so forth and so on. And that could actually invoke much more change than what we're seeing now.
I've just got an eye on the time. I want to leave time for questions, because I'm sure we've got a lot of people who want to ask you things, but just, you know, I have to get onto the sort of the ethereal question at the end. You know, if you could change one thing, what would it be? But I mean, if you could look, you have such a unique perspective on the NHS, and you can compare it and contrast it with other systems around the world, places you've worked, your unique experience. What do you see that you would change about the NHS?
Well, let me start by saying that I have a very positive view of the NHS, even more positive now than when I came. I think it is a clear organization. There is the leadership at the top. I'm talking about the likes of Simon Stevens and Amanda Pritchard. They're really good people, and they really understand what they're talking about. And so that's fine. That's perfectly fine. And I am also positive about the changes things are going to make. I think the NHS could be a little bit more relaxed about itself. And I'm going to give you one example. There is not a lot of freedom of speech in the NHS. So a lot of people in my previous position, chief executive of big organizations, have a very good view and a very nice opinion about what's going to be good for the system and what needs to be improved. but they do not have a lot of freedom to speak up, because that's not actively encouraged, because we all have to be in line with the party. It's always like the Soviet Union once in a while, where we all have to follow the Kremlin, and actually an alternative view is not really appreciated. I think the NHS could gain a lot from people with alternative views who do speak up. I'm not saying that we should immediately do what they say, but they could at least spark a little bit more discussion in the system. And now it is very centrally led. During COVID, we were not even allowed to talk to journalists when NHS England, some central person somewhere, I don't know who it is, actually rubber stamped it. That was ridiculous, because I think there would be a lot of people with a lot of sensible ideas that actually could make the system even better than it is now. But a lot of people are afraid to speak up. And I think that that's not a good thing about the culture in the system.
No, I mean, that comes through a lot with people who contact me. When the boss of comms at NHS England, Simon Enright, he's just off to go and work at Buckingham Palace now. He's got the job of the Prince Charles press secretary, which I'm not sure which is the frying pan and which is the fire, but it'll be an interesting to follow his career. So looking back there, it's about speaking up, I suppose. What about the changes in COVID? If you could absolutely nail in one thing that COVID has given us, what do you think that might be?
Yeah, I think the integrated working. So the thing that the GPs started during the second wave, the virtual wards, where patients could stay at home that otherwise would have been admitted to the hospital, or patients could be discharged from the hospital to their homes with a little bit of help of technology at home, but coordinated by GPs, was a fantastic example of innovative thinking. And that's not only applicable to COVID. We could also do that for pneumonia, we could do that for asthma, we could do that for diabetes that's a little bit out of control. But now everything funnels and drains into that hospital. And actually with things like virtual ward, we can actually empower GPs and primary care to take care of their patients without admitting them to hospital. So that for me was one fantastic example where when people start working together, you can really improve the system.
Yeah. Well, let's hope that is a legacy. John, do you want to lead us through some questions?
Yeah, I've got several actually. If I may, I'd like to go to Julie first of all. And Julie says, if it's useless, why do we still do it? There seems to be a big need to disinvest and stop doing things or reconfigure. How do we enable this post-COVID when the necessity might be perceived as being over? So,
yeah.
You know, COVID as a necessity has driven innovation. How do we make sure that innovation continues when the necessity is taken away?
Yeah, I fully agree. I think, so the answer is already in the question. So I think many clinicians will know that a lot of things that we do are not really useful for patients. So we should disinvest in them. But there is an interesting thing about the word disinvest, and that's the part that says invest. So just take it away, take the money away, and then think that it will just disappear is not going to work. So you really need to make a plan where you actually gradually decrease that activity, and in the meantime, increase alternative activity that is more applicable to the patient's need. So again, you can make changes in the system, but you need a little bit of extra investment to make that transformation. And that's not what we've been doing in the past few years. There was so much pressure on cost improvement, cost saving, reducing cost, that it almost paralyzed transformation.
It's interesting that we talk about disinvestment because we got NICE, the National Institute for Health and Clinical Excellence. They tell us what to invest in. Yeah. And what to buy. Also, part of their job is to disinvest in some redundant procedures or out-of-date procedures or procedures that don't work. I can't think of a single thing that we've disinvested in on the advice of NICE. I can't think of one thing.
I think that's true, but that's also, and now I think I also have to blame myself, that's also how medical research is working. We do lots of clinical trials, but it's also extra things on top of something else. We never do a clinical trial where we say, well, if you're 80 years old, do you really still need a cholesterol lowering drug, or can we stop it? It would be an easy trial, just randomize 80-year-old people between continuation of that drug and stopping of it. We never do those trials, never ever. We only do add-on trials, but we never do stopping trials.
Well, we do bonkers things. I mean, when my mum was alive, I remember I used to go in there with cream cakes on a Wednesday. I always popped in there. I went in one Wednesday and she said, I can't have any cream cakes anymore. I said, why? She said, well, the district nurse has been in and she's done a summary of my diet. And she said, it's going to put my cholesterol up. And I think at the time she was 87.
Yeah.
And I said, you know what, Mum, let's see how high we can get your cholesterol by the time it's next taken.
Well, I so much agree with you. So my grandfather was 95-year-old, and then somebody prescribed him a cholesterol lowering drug.
Yeah, the statin. Yeah.
So maybe you have an advantage 20 years from now. I mean, then you're 115. What do you think? And then fortunately, he didn't take it.
Yeah, exactly. Right, John, what else you got?
So I've got from Simon, it's a bit of a niche question, but important all the same. He asks, do you have any thoughts on what the optimal relationship should be between COO and CEO? And should the COO also fulfill the role of the deputy CEO? I'm sure everybody's enjoyed the acronym. Chief Operating Officer, Chief Executive Officer.
I know, but I'm the last person to ask these questions, because I hate these organigrams and who should be where in the organigram and who should have a dotted line between them and then a straight line. And then, well, it's horrible. Whatever works. So in the system that we worked at UCLH, we did not even have a chief operating officer. It were actually the medical directors that were responsible for not only the medical things, but the whole operation. And that worked beautifully well. And for me as a chief executive officer and for our chief nurse, we both felt sometimes as a chief operating officer because we intermingle things and it worked well. So yeah, it depends a little bit on the type of organization and what you want to achieve, but I don't think there is a golden rule. And to be totally honest, so I think my deputy chief executive was our chief financial officer, Tim Jackett, who is now the interim chief executive of UCLH. He is not only a financial genius, absolutely genius, but he's also so interested in everything else that happens in the hospital. He's almost a chief operational officer himself and a little bit of a CEO. And he also has an interest in research. So I think that's the way to run an effective board, that people have overlapping interests and overlapping responsibilities.
Sounds like he's got the job as your successor. I know, he sounds like a good guy.
Well, he could have had it, but he's just the interim. The substantive successor is coming in August.
Who do you know who it is? Can you tell us?
Yeah, that's David Probert. He's now the chief executive of Moorfields Eye Hospital. He's a fantastic guy. I'm very, very happy with his appointment. Actually, with Tim's interim appointment, but certainly also with David Probert's substantive appointment. I think it's just what our organization needs.
Yes, it's interesting. I did read that. I'd forgotten it. And of course, Moorfields have been very adventurous, haven't they, in the way they've done their franchising effect with outside the hospital.
Yeah,
and
he is entrepreneurial. He supports research. They did fantastic things with artificial intelligence, with eye scans. Moorfield is a specialist hospital. UCLH, of course, is also for a very large part a specialist hospital. David has a long history before he went to Moorfields at UCLH, but also at the Royal Marsden, at Guy's and St. Thomas's. I think he's the fantastic choice. I'm very happy with that.
Well, we'll find out, I guess. All right, John, another one, quick one.
Marilyn says, to what extent, Marcel, are you concerned that the NHS itself is under threat? And what steps can be taken to ensure its longevity?
Well, it was not always easy in the NHS, but I've never felt that it is under threat. So I think the system is good, has proven itself absolutely during COVID. And now again, with the outroll of the vaccination, the whole world is looking at the UK. They're so jealous on how extremely well that's going. And that's just the power of the NHS. So I think it's more the other way around, that I now hear from many other people in other countries that they say, well, we may need a national health system because look how it really can work for the population. So I don't think the system is under threat. I think we just need to stick by the principles of the NHS. And again, and things like private hospitals and all these things are just a distraction. They're not helping us. They're not helping the population. And actually, they're just diluting the workforce. So I don't think the system is under stress, but we just need to stick with its principles.
If I could just ask you, there's a question here, John. If I'm just going to jump in, because if I dovetail it in, if you don't mind. The question is from Ozren Tosik. Ozren, thank you. He's talking about the relevance of the Nightingale hospitals. You know, what we didn't really make much use of, or certainly not the one at Excel. It's been used for jabs now. Do you think there's a role for the Nightingales now in terms of waiting lists? Because you know, all hospitals have got a horrible waiting list now. Can we turn them into, I don't know, cataract factories, or can we do hernia production lines?
No, we have fantastic hospitals that can do cataract factories and hip replacement surgery, as long as we invest in those hospitals and the staff in those hospitals. And the last thing we want is to have an ugly conference center turned into a cataract hospital, which will never be a cataract hospital because it's not designed to be a cataract hospital. So it's going to be very costly, very ineffective, and very stupid. And we don't even have the workforce to work there. So why don't we just invest all that money into NHS hospitals to actually get out of them as much as possible, to allow them to work 6-7 days a week, evening working, all these things, pay our staff very well. And then we will actually get rid of the waiting list, but not by opening fancy new, you know, factories or barns where we think that they will solve the waiting list, but they will not.
That'll be great news to Jan Flint, who's running the Excel Centre vaccination team. She's not going to get kicked out.
I mean, vaccination you can do everywhere. You can do it in a shopping mall. You can do it in a bus station. Yeah. But cataract surgery is a little bit more difficult than vaccination.
Well, Médecins Sans Frontières do it in the jungle.
Irene, I'm just very conscious we've got 3 minutes, Roy, so I'm going to move along quickly. Irene asks, post-COVID, given your experience, what would you recommend management educators in the NHS do and change?
Yeah, good plan. So I think I've seen the most effective managers actually being managers that put on scrubs, worked with their teams, understood what was going on the shop floor, did attend MDTs and other meetings, and handover between nurses, etc., and thereby get a very, very clear understanding of the needs of their teams, and then could very much better support their teams. That's amazing. I think likewise, the NHS would be a better place if much more doctors and nurses would follow a little bit of management training to understand a little bit better organizational patterns in the hospital, finances, how to work with teams and logistics. So I think this cross-fertilization between the two disciplines, bridging the gap between managers on one hand and professionals on the other hand, could be very, very beneficial.
And that's a terrific note, really, perhaps for us to leave it on. Marcel, I have so much enjoyed talking to you. Perhaps we shouldn't leave it quite so long next time. Perhaps we should have an international health chat to see how you're getting on. Listen, you've done a fantastic job since you've been here. We're enormously grateful to you for the job you've done. Thank you for your leadership during COVID, which has been an extraordinarily difficult time for us all, and you've led a complex organization through it enormously well. We'll miss you, and I'm sorry that you're going, but thank you so much for spending your time with us tonight, and we're really grateful. Thank you very much.
Well, thank you, and I'm certainly going to miss all the wonderful people I've met in the NHS and in London and at UCLH.
Well, that's nice. What I'd like to do now, I'd like to thank Marcel on behalf of the Institute of Health and Social Care Management. Thank you. I've got to thank Richard as well. Thank you to Roy as well. Thank you to all of you for coming in and spending some time in Marcel and Roy's company this evening. I do hope you enjoyed it. Just a date for your diaries. We're having a virtual conference, No Going Back 2, No Going Back the sequel, to explore further things that have emerged during the COVID pandemic that we would like to now cling on to and fight to preserve. And that's on the 21st of April at 2 o'clock in the afternoon. Do please go to the IHM website and reserve your place now. By the way, that is also my birthday, so I'm expecting cakes and heaven knows what else to be aplenty. All it remains to be now is to say is we're going to stop the recording any moment. If you'd like to just have 10 minutes or so in the virtual green room afterwards, just to unmute and say hi and thank you to Marcel, then do please hang on. But right now I'm going to say thank you very much to all of our viewers and listeners for coming in this evening and watching. And from us, it's good night.